Hey, hello everybody. It's my pleasure to be here talking to you today. I am Dr. Andrea Furlan. I am a physician specialist in physical medicine rehabilitation in Toronto, Canada. I'm talking from Toronto, the cold weather here, and it's my pleasure to talk to you today about chronic pain. So I'll start sharing my slides and see if you, okay, let me put in presentation mode. Okay, so I hope you can see my slides. So I'll talk to you about pain management, but mainly I want people to understand that there are three types of pain, at least three types of pain, and each type of pain is treated differently. So that's why it's important to know what they are. And here are my associations. I am an associate professor at the University of Toronto. I am also a scientist at the Institute for Health, a staff physician, senior scientist at Toronto Rehab. I am chair of ECHO Ontario Chronic Pain and co-chair of ECHO Occupational Environmental Medicine. So at the end of this presentation, I hope our participants will be able to first define what is pain. It's not easy to define, although everybody feels pain, but to define and understand what it is so then we can treat is a different thing, right? Also for you to explain, you'll be able to explain the three types of pain and discuss treatment strategies for each type of pain. I have some conflicts to declare. There's nothing really to do with this presentation, but I have research grants. I am of advisory committees for the work compensation here in Ontario. I received unrestricted educational grants from the Canadian Generic Pharmaceutical Association. I have a YouTube channel, and I do receive payments in some of the advertisements that people see. When I mention products that in my videos and I tell people they can go to Amazon to buy them, I do receive a commission from Amazon. I am an author of a book for people with chronic pain, and I do receive royalties from the book. And I have online courses on my website about pain, and those courses are paid. Okay, so let's start. So pain, we all feel pain, right? And we know that, for example, here, this was a drawing done in the 17th century by René Descartes. And he was the first one that actually connected the injury to the brain, and saying that pain is actually felt in the brain. Although we do, if you put your toe on the fire, it looks like the pain is in the toe, in your foot, but actually pain is in the brain. So he helped, but not a lot, because over 3-4 centuries, almost 5 centuries, nobody really cared too much about studying pain. Everybody thought that, well, maybe if you eliminate the fire, if you eliminate the danger, then pain will go away. Or if we cut the wires, these nerves that carry the information from pain to the brain, then the pain will go away. But we know that if we cut the nerves, then you have phantom pain, which is a differentiation pain. You don't eliminate pain. So pain is more complicated. So it was really a recent, in the last 50, 60 years, in the 21st century, that this pain system started to be challenged and to be studied. And you might have heard about the gate control theory that was published by two Canadians here at the McGill University in Montreal, that they said, wait, pain is not that simple. And there is this ascending pathway. This red arrow here shows the ascending, the bottom up pathway. The brain does a lot of things, and then the brain activates this descending top-down modulation pathway, and a lot of things happen in the spinal cord, brain stem, and so really the field of pain started. It's new. Like the pain system is a new discovery for medicine. Like if you think about when was the digestive system, cardiovascular system discovered, it was 400 years ago, but the pain system mainly 60 years ago. So this makes it complicated because this pain system can malfunction, can break, can have diseases on itself. And chronic pain, the majority of chronic pain is actually a disease of the pain system itself, not only like if a person has chronic pain, let's say in their toe, in their foot, it doesn't mean that their toe or their foot is in the fire for many months or many years. Why the person is still having pain after the injury healed, after they had surgery for the problem, after the injury, or even some people, they don't even need an injury to have chronic pain. They don't remember, like fibromyalgia is a type of chronic pain that it hurts everywhere. But these people didn't have injuries everywhere in their body. They just feel pain everywhere. It's because the pain system is malfunctioning. So this pain system can malfunction in the periphery, in the central sensitization is the spinal cord, or in the cortical reorganization. So that is the third type of pain. So when we talk about the three types of pain, that I'll explain this in this talk, that is the third type of pain. When chronic primary pain, here, chronic primary pain is when the pain system itself is the origin of pain. So by definition, pain is an unpleasant, any pain, not just chronic, acute, chronic, any pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Chronic pain is defined when this pain lasts 3 months or more, or it's the pain that persists after the normal expected healing time. So you need to know what is the expected healing time for this injury. Well, if it was supposed to heal, and I can see that you have healed because I can examine your shoulder. Your shoulder is moving much better. We did surgery, we fixed the problem, but the person continues having pain. They developed chronic pain. And chronic primary pain, which is that pain where the origin of the pain is due to that sensitization, either peripheral, central, or cortical sensitization. We call this primary because the pain is not secondary to something. Okay, so chronic primary pain is when pain has persisted for more than 3 months and is associated with significant emotional distress and or functional disability, and the pain is not better accounted for by another condition. So the International Association for the Study of Pain plus the WHO, the World Health Organization, they teamed together and reclassified pain. This is the International Classification of Diseases, version 11, just recently published 2019. So if you read the ICD-11, you will see that chronic primary pain now has its own classification. And chronic primary pain can be chronic widespread pain, chronic regional pain syndrome, chronic primary headaches or orofacial pain, chronic primary visceral pain, and chronic primary musculoskeletal pain. So all these chronic primary pains, what they have in common is the mechanism of pain is nociplastic. The secondary pains, secondary to surgery or secondary to a nerve injury, secondary to a visceral problem, they can be nociceptive or neuropathic. So those are the three types of pain: nociceptive, neuropathic, and nociplastic. I'll come back to that. So I have a video on my YouTube channel that I explain this to my patients. I explain this in plain language because it is hard for my patients when I tell them, well, you have this kind of pain and the treatment that we use for nociceptive is different from neuropathic, is different from nociplastic. They need to understand that I'm making a diagnosis, and sometimes people have mixed pain. Sometimes they have all three pains, which makes it complicated, but that's life. And nobody said that they can only choose one type of mechanism of pain, right? So the way I explain in that video, it's very illustrative of these three types of pain, and I'm going to explain this to you. It's like the alarm system of our house, okay? It's exactly the same thing. So the pain system is like the alarm system. If you install an alarm in your house, you want the alarm to be noisy, loud, because you want it to make noise if there is a fire, a smoke in your house, or if there is a burglar, someone intruding your house, or if there is a carbon monoxide. So what do we do is you install sensors in the alarm, in your rooms, in your kitchen, and then you want the sensors to detect danger. The sensors then send a signal to this box on the wall. This box on the wall here you can modulate the signals, you can give passwords to different people, you can cancel, you can say, I'm going away, or I am inside of the house. So you disconnect the alarm system. But then this box on the wall will connect with an office, and the office, the alarm system company, they will decide what they send to your house, the police, the fire truck, the ambulance. So our alarm system has the same thing, because our alarm system tells us when our body is in danger. So if our body is in danger because we have sensors in our skin, in our organs, in our viscera, on the bones, tendons, if our body is in danger, then you want pain to happen, because pain is the alarm system of your body. And the sensors, they go to the spinal cord or the brain stem, and then that's equivalent to the box on the wall. And then from there, they go to the brain, where the brain will decide what to do. The brain will decide if they activate the descending inhibitory pathways or not. So when we have nociceptive pain, it's equivalent of having a fire in the house. So you do need to call the ambulance, fire truck, police, because there is something wrong. There is a fracture, there is a damage, there is an injury, there is an inflammation. So inflammatory pain, fracture, a lesion that you can see, this is nociceptive pain. And how do we treat this? We treat this by removing the injury. So if there is a nail in your skin, and you have to remove the nail, treat with antibiotics, give some anti-inflammatories, apply ice. That's how we treat nociceptive pain. You can give opioids, because opioids are good for nociceptive pain for a short period. Surgery is a type of nociceptive pain because it causes trauma, it causes disruption of the tissues, right? Now, neuropathic pain is the pain that comes from a lesion or disease of the somatosensory system, nervous system. So this includes the peripheral nerves, the brachial plexus, lumbar sacral plexus, the nerve roots, the spinal cord, the thalamus, the cortex, the cerebellum. So if a person has a stroke and the stroke affected those areas, the thalamus, for example, they will have thalamic pain, and that's neuropathic pain. If a person has herpes zoster, which is caused by shingles, then they will have a peripheral nerve and radiculopathy disease, that's neuropathic pain. So you can see where it is. In the house alarm, this would be equivalent of having a short circuit somewhere, and then let's say you open the cupboard of your kitchen and the alarm goes off, and then you call the electrician, they come, they fix the short circuit, and the alarm stops making noise. So nociceptive neuropathic pain, you can localize. You know what is the disease. There are kinds of secondary pain, and they can be chronic pain. I know people that have multiple inflammatory problems, and they can be chronic. And for example, trigeminal neuralgia is caused by a nerve lesion in the trigeminal nerve. And people with trigeminal neuralgia, sometimes they have pain every day, episodic pain, or many days during the month. But that's a kind of secondary pain, and that's a kind of neuropathic pain. Now, nociplastic pain is defined as, is the third mechanism of pain. It's the pain that arises from an altered nociception despite no clear evidence of nociceptive and no clear evidence of neuropathic pain. So you cannot find nociceptive, you cannot find neuropathic, the person continues feeling pain, the pain is real, they are not inventing, this is not emotional pain, this is not psychological pain, the pain is real because there are areas of the pain system that are functioning abnormally. And of course, the fourth type of pain, it's pain that you don't know what it is. I don't know, it's idiopathic, I can't find any signs of nociplastic, neuropathic, or nociceptive. In chronic pain, the majority are nociplastic. So let's talk a little bit about where these abnormalities can occur, right? I told you that it can happen in the peripheral nerves, this neuroplasticity. can happen in the periphery, in the spinal cord, in the brainstem, cortex, all those areas where the pain system resides, including the neuroendocrine system, even areas outside of the nerve system, the endocrine, we do have alterations there too. So what happens with peripheral sensitization? Mainly three things: activation, modulation, modification. And these are phases of this plasticity. Activation means that there is a lot of impulses coming on from the periphery, and there is a wind-up phenomenon, which means that that receptor, the nociceptor in the periphery, will continue being activated, even sometimes despite the lesion has been healed already. But that's activation. Then we have modulation, when that receptor, the nociceptor in the periphery, and this could be a nociceptor in a viscera, in a bone, in a tendon, in the skin, okay? When you think about nociceptor, think about nociceptors everywhere in the body. Modulation means that now they're being modified. There is phosphorylation of these receptors. The ion channels, especially the NMDA receptors, are now open. They're usually blocked by glutamate, by magnesium. But when there is phosphorylation, because there's a lot of substance P and glutamate, this phosphorylation opens this channel, magnesium gets out, and then the channel is now open for calcium. And then the last stage is modification of that nociceptive receptor, because what happens here is almost, we are saying that this is irreversible, although I don't like to say it's reversible, because I always tend to give hope to my patients that we can revert chronic pain, but there is now altered gene regulation. Now, when we go to the spinal cord, things start getting a little bit more complicated. We still can have activation, modulation, and modification in the spinal cord. This is what I'm going to try to show you with this slide here. This is the synapses happening, the pain synapses in the spinal cord. It happens in the dorsal horn. Okay, this is the afferent neuron, the primary neuron, the first neuron bringing information from the periphery. This information that is coming from the periphery can be because there is the foot is still in the fire. So if the person is still keeping their toe in the fire, so this release of glutamate and substance P will continue. But sometimes, because of that peripheral sensitization, the toe is not anymore in the fire, but that nociceptor is still sensitized and is sending this information via the afferent neuron. It comes here to this synapses. So what happens is this glutamate and substance P, they will activate these receptors kainate and APM in the second neuron. This is the second neuron that will send the message to the brain. And then the brain will analyze what is going on, and then will activate the descending modulatory pathways, which may include activating this inhibitory interneuron. This inhibitory interneuron will put GABA in this synapses, and GABA stops this synapses. In the acute phases of central sensitization, which happens within hours or days, we see a lot of these neurotransmitters in the synapses, but now because that NMDA receptor is not blocked by magnesium anymore, it's open, now glutamate can activate this NMDA receptor, and when it does this, calcium can enter this second neuron. And when this happens, this second neuron undergoes a lot of modifications. That's the modification phase. However, the brain still has the capacity to activate this interneuron and put GABA in the synapses and stop this. However, in the late phases of central sensitization, when you don't have impulses coming from the periphery anymore, because the lesion is healed. It's gone. There's no more. You don't even need substance P and glutamate coming from the primary neuron. What happens is this synapses here enters into a loop, and it activates itself, because now there is gene expression. And with gene expression, you have this wind-up phenomenon, you have this alteration of the synapses. But you still have the interneuron here that can inhibit this, controlled by the brain, until you lose this ability. And this is the disinhibition phase. When you lose, because we see these interneurons disappearing from the dorsal horn. When you lose this, you have this altered descending modulation from the brain. You are unable to block this synapses. So what we have here, this is a picture that I have in my book. I explain this to patients. I say, well, a normal synapses in the spinal cord is one that, yeah, if you are receiving, let's say, 2 painful impulses from the periphery, the spinal cord just passes the information to the brain, doesn't alterate, does not augment, does not amplify, does not diminish, just pass the information. However, the spinal cord feels that it has to have a role, and this is also controlled by microglia in the spinal cord. So the spinal cord will amplify this information. It's almost like telling the brain, listen, you need to know this. I'm receiving the signals. You're not doing anything. So do something, and it's going to amplify. So now the brain is receiving 5, 10, 20 information. And in the late stages of central sensitization, you don't even need the injury from the periphery anymore, because the spinal cord now is continues sending this information to the brain, and the brain becomes overwhelmed. So central sensitization, it starts in the spinal cord, but affects everything, because the brain doesn't know what to do. The brain doesn't know how to control this, doesn't know what to do with this information, gets lost. So the problem is, if we give opioids when the person has central sensitization, when that synapses is activated, remember I told you that the NMDA receptor is very important. If you give opioids, opioids is going to activate that receptor, and it's almost like putting gasoline on the fire. You're just going to amplify that central sensitization, except for methadone. Of all the opioids, methadone is the only one that does not activate the NMDA receptor. Actually, it blocks the NMDA receptor. So if we want to treat central sensitization and a person is taking opioids, could be codeine, morphine, tramadol, hydromorphone, fentanyl, any opioid, we switch them, we change this opioid to methadone, and the opioid-induced hyperalgesia reduces. So this is how I explain opioid-induced hyperalgesia. I have a video also on my YouTube channel. When your doctor started giving you opioids, your pain was very high, and you started increasing the dose of opioid, your pain went down, 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 because that's what opioids do initially. But then your doctor continued increasing the dose of opioid, hoping that this line here would go down and your pain would be zero. But your pain was never zero with opioids, and the doctor continued increasing the dose. And now this opioid is acting in that synapses in the spinal cord, and it's what's generating this chronic pain that you have. So when I tell people about this, they say, oh, so what do? I say, let's try to decrease the dose of these opioids slowly so you don't have withdrawals, and try to find this optimum dose. The patients feel a lot better, and most of my patients that I try to do this, they stop taking opioids completely, and they tell me, well, I still have the same pain. I don't know why I was taking opioids, or I'm better, my pain is better. I've published a paper in JAMA last year, the Journal of the American Medical Association, where we randomized 604 people taking opioids for chronic pain. They were taking opioids for many, many years, and 305 were randomized to an education and support intervention to help them to reduce the dose of opioids, and 303 did not receive anything special, just usual care. And then we measured if their pain was better, worse, or the same, and if they were able to discontinue opioids. So you see here the results. In the group that received education and support, pain reduced, but also in the usual care, there was no significant difference between the two groups. However, there was a significant difference in people discontinuing the opioids in the group that received education and support. So this shows that education support goes a long way, and you don't make their pain worse. Now, let's talk about cortical reorganization. This is the interesting part of nociplastic pain because a lot of things happen in the brain stem. I don't have time to explain to you everything that happens in this area. I do have a course that I'm preparing and I'll put on my website in the next couple of weeks. But it's super exciting because one of the things that we know that pain does to the brain is this decrease in the prefrontal and thalamic gray matter density. And this is very serious because you know that if we lose gray matter, the brain doesn't function so well. And has a consequence of having chronic pain. And it's equivalent, a person having chronic pain is equivalent to a person that is aged between 10 and 20 years. So no wonder our patients with chronic pain, they complain about forgetfulness, mental fatigue. They talk about a brain fog. They talk about, I can't read a book. I can't pay attention to things. It's because they are losing gray matter. So pain has a big consequence in the brain. Not only the size of the gray matter, but also the connectivity, the functional organization. So these researchers, they looked at a healthy population. This is the first column here, chronic back pain, people with CRPS, complex regional pain syndrome, and osteoarthritis. And then they looked at 5 different networks, and they found that the default mode network, which is the first row here, showed significant differences in the brain. I cannot see the differences with my eyes, but the computer can, and the computer detected differences in the default mode network of all these 4 pain syndromes, which shows that not only pain affects the brain, but different types of pain affect differently the brain. And the default mode network is very important for the resting state, when the person is resting, not doing any activity, not doing any cognitive activity. This is another fascinating study. This is pain imaging of the insula. This is the insular cortex right in the middle of the brain. Insula is part of the limbic system. And what these researchers showed, each dot here is a study. It's not a patient. Each dot that you are seeing here, each circle here is a study of multiple patients. And you see here that the anterior insula and the posterior insula, what happens is that people who do not have any chronic pain, people who are healthy, they don't have any chronic pain, if you do a stimulation in the laboratory in their body with pain, they will activate the anterior insula. Here, the black dots are the studies done with healthy people with no chronic pain, and this oval here is the meta-analysis of all these studies. Now, if you get people with chronic pain, they're all the purple dots, they're activating the posterior insula. And there is a problem because the anterior insula and the posterior insula, they have different functions. So these are parts of the limbic system that the person feels more their interoception, they feel more the inner parts of the body. I'll give you an example. I had a patient with chronic pain, back pain. And I think her insula, she was activating the posterior insula because she told me that the pain was not so bothersome to her, but it was her esophagus. She said, every time I cough or I burp or I swallow, I feel air coming out of my esophagus. That bothers me a lot. And this is interoception. There are a lot of people that they are bothered by the noises that are made by their joints. You know, when you move your neck, we feel the cracks in our joints. That's normal. But some of my patients, they are profoundly disturbed by those noises. That might be because they're shifting from the anterior insula to the posterior insula, and that's neuroplasticity. That's a type of nociplastic pain. I mentioned to you also that the neuroendocrine system is affected by plasticity. So this is in the normal circumstance. We have an stressor and then the amygdala. Like the amygdala is the center of fear. It's activated. The hippocampus is the center that is part of the limbic system, but is the memory, is the relaxation. When people do meditation or mindfulness, they activate the hippocampus. It's the relaxed center when you are creating memories. So normally you have the stressor, amygdala lights up, hippocampus can inhibit this, hypothalamus will release CRF, which will activate the pituitary gland, and then the adrenal cortex, and then a lot of the stress hormones, the noradrenaline, glucocorticoids, the CRF also will go to the spinal cord and periphery and release mast cells. The mast cells in the dorsal horn will activate the ascending pain, and the descending pain in modulations will be activated. This is normal. However, in a person that has chronic stress or early life stress, this system is deregulated. So there's plasticity in the system. So the system is not functioning the way it should, because the amygdala will be overactive, the hippocampus will be taking a vacation, it's not doing what it's supposed to do. There will be a lot of CRF, a lot of ACTH, a lot of glucocorticoids. The mast cells in the dorsal horn will be super active, therefore activating the ascending pathways and inhibiting the descending pathways. How do we regulate this? How do we fix this pain system? It's not by medication, it's not drugs. It's by exercise and cognitive behavior therapy. So I tell my patients, if we want to revert nociplastic pain, we need to use exercise for the mind and exercise for the body, because when the body starts moving, then it sends messages to the brain. Oh, you know what? This person is not broken. You know, this person, you know, the lesion is healed. Look, the shoulder can move. Yeah, the surgeon did a good job. Look, the range of motion of the shoulder is better. So that exercise for the shoulder is actually retraining the pain pathways. And the cognitive behavior therapy is good because that will reduce the catastrophization, the anxiety, the worries, the perceptions. So everything will come back to normal. The insula will then move to the anterior insula. The amygdala will stop being in fear all the time. The hippocampus will start inhibiting this anymore. So we know there is evidence from multiple studies that physical exercise, that's why I tell my patients the 2 M's, movement and mind exercises. So when does this acute pain transform into chronic pain? When does nociceptive or neuropathic pain transforms into nociplastic pain? The process starts immediately. The central sensation takes longer and involves LTP, long-term potentiation, which is similar to short-term memory and long-term memory. So this means that the longer the person continues feeling that acute pain, subacute, they are creating more memory of pain in the hippocampus and in all those synapses. They are creating those synapses, and I tell people, you need to undo those synapses. It is possible. They lose the descending inhibition of the brain stem. There are some irreversible epigenetic changes. So usually by 3 months, the pain transforms from nociceptive to nociplastic. And remember, we don't want to prescribe opioids if you suspect nociplastic, because you are going to put gasoline on that fire because of the NMDA receptors in the spinal cord. This paper is amazing because these authors, what they looked at the brains of people that had acute, subacute back pain. So here, everybody started with acute, subacute pain here. And then they follow these people with questionnaires and brain imaging up to 1 year. So visit 4 was 52 weeks. And look what happened. Those that persisted, this first graph here, is those who persisted with back pain 52 weeks after. Look, the red diamond is the activation of nociceptors, the somatosensory area in the brain. When they started having pain, they were activated, but 52 weeks, they were not having pain anymore. So no more nociception. but the emotional areas of the brain now were the ones lighting up, which means that now the pain that these people were feeling was more like a memory of that pain. It doesn't mean, again, I have to say this over and over, the pain is real. The pain is real. Your patient is not faking it. They are feeling the pain, but it's not coming from nociceptor. It's coming from this memory in the brain. And those who recovered, the SBP recovered, they don't have the nociception anymore and they don't have the emotion areas of the brain. And look, when this happens, the shift happened around 10 to 12 weeks. So it's around 3 months that the pain transforms from subacute to chronic. Why some people do this and others don't? The orange boxes here talk about predisposing factors, maybe genetic influences, biological factors, environmental factors. But once they develop this central sensitization, then they have fatigue, sleep difficulties, autonomic disturbance, mood problems, other symptoms, including migraines, irritable bowel syndrome, difficulties with cognition that affects their whole life. So no wonder chronic pain is one of the major problems we have in the world. And people who had adverse childhood experiences, they are more prone. The more ACEs they have, the more chances they have of developing chronic pain in adult life. And the ACEs are classified into 3 categories: abuse, neglect, household dysfunction. Abuse can be physical abuse, emotional abuse, sexual abuse, neglect, physical neglect, emotional neglect. Household dysfunction include living with an adult that had mental illness or one of the relatives that were incarcerated, seeing if the child saw the mother being treated violently, if one of the adults in the house had substance abuse, or if there was divorce of their parents. So chronic pain is one of the most underestimated healthcare problems in the world today. It affects 1 in 5 adults, 1 in 3 seniors. So we need to see chronic pain as a disease. Like the WHO, World Health Organization, recently recognized chronic pain a disease on its own rights. That's why they resulted in these revisions of the ICD-11. Chronic primary pain, again, is pain that is in more than one anatomical region, persists or recurs for longer than 3 months, associated with significant emotional distress and or significant functional disability, and the symptoms are not better accounted by another diagnosis. So it's not nociceptive, it's not neuropathic. So examples can be chronic widespread pain, that's fibromyalgia, CRPS. Chronic primary headache can be migraines or chronic tension headaches, etc. So now let me talk to you a little bit about neuropathic pain, because neuropathic pain has some similarities with nociplastic pain, but then you can find a cause for the neuropathic pain. And here is a list of what can be causing neuropathic pain. So if your patient has a metabolic disorder, and then you can, and the picture, their pain diagrams, their pain is typical of a peripheral diabetic neuropathy, then this is neuropathic pain. This is not nociplastic pain. Or if their pain is caused by toxins, nutritional deficiencies, neuropathies like zoster, postherpetic neuralgia, HIV, leprosy, or if they have autoimmune disease like multiple sclerosis, or if they had an injury like spinal cord injury, a brain injury, an amputation, or degenerative compression injuries like carpal tunnel syndrome is neuropathic. Radiculopathy, a stroke, a brain hemorrhage, a tumor, primary tumor or metastatic, an inflammatory disorder. Rheumatoid arthritis can cause neuropathic pain too. Hereditary neuropathies, channelopathies, chemotherapy induced. So you need to be careful that you don't miss one of these neuropathic pain diagnoses. As I said, people may have mixed kinds of pain, which makes more complicated, and mixed type of pain is common in cancer, low back pain, osteoarthritis, post-surgical pain. And people who have mixed pain, they have more comorbidities, worse psychosocial problems, more complex presentations, and worse prognosis. How do we treat neuropathic pain? So we're talking about neuropathic. Even exercises are good for neuropathic pain, yes, especially for children who have complex regional pain syndrome. We can treat with transcutaneous electrical nerve stimulation, percutaneous electrical nerve stimulation, graded motor imagery, cognitive behavior therapy, acceptance commitment therapy, acupuncture, electromagnetic therapy. There are non-invasive transcranial brain stimulation, like repetitive transmagnetic stimulation, and this is all for neuropathic pain, chronic neuropathic pain. We can also use transcranial direct current stimulation, spinal cord stimulators, spinal magnetic stimulation, frequency modulated electromagnetic neurostimulation. What about diet in chronic neuropathic pain? We can use, common sense. I think there's no one diet that will eliminate your neuropathic pain from your patients. But for example, in chemotherapy-induced peripheral neuropathy, they summarized 22 studies and they found a couple of things that helped these people with chemotherapy-induced peripheral neuropathy. What about diabetes? They also found some things in a meta-analysis of 13 studies. And CRPS, there were 3 studies and they looked at vitamin C, magnesium, St. John's wort. So the results are, it's really hard to study diet for any disease, including chronic pain, but that's what this meta-analysis and systematic reviews showed. In terms of pharmacological management of neuropathic pain, in Canada we have, it's not a guideline, but this is more like a consensus statement, and we use this in Canada. We use as first line for neuropathic pain, tricyclic antidepressants, gabapentin, pregabalin, and the serotonin, norepinephrine reuptake inhibitors, SNRIs. Second class would be the tramadol or other opioids if they don't have nociplastic pain, right? The third one would be the cannabinoids. And then the fourth line would be other agents like lamotrigine, topiramate, valproic acid, methadone, SSRIs. So it is really important that when we are treating any kind of pain, not just neuropathic or nociplastic, but any kind of pain, that we involve an interprofessional team. Nurses and pharmacists, they have a key role in treating chronic pain. Social workers, psychologists, occupational therapists, physiotherapists, because they will help to activate our patients. A lot of people with chronic pain, they have fear of movement. They are afraid of some postures and ergonomics. They do need to lose that fear because that fear is maintained in the amygdala. And if you have the amygdala that is hyperactive, that pain will not go away. And of course, teach your patients self-management and brain retraining strategies. Chronic pain can be curable. Yes, there are a lot of studies. This one, they did cognitive behavior therapy. This was published in 2013, more than 10 years ago. So we know that cognitive behavior therapy can erase some of those areas in the brain that are responsible for the maintenance of that nociplastic pain. We know that yoga can increase the size of the cortical areas, can decrease the areas of the brain that are hyperactive. And again, these papers were published many years ago, almost 10 years ago. So we should be, it takes so long for evidence be put in practice. I still see a lot of people doing medications only or interventions body interventions. And more recently, published in 2021, another type of mind-body intervention is called pain reprocessing therapy, that also these patients were, the pain, chronic pain was eliminated. We're not talking about managing pain, we're talking about eliminating, curing chronic pain with cognitive behavior therapy, yoga, pain reprocessing therapy, mind-body interventions. So try those first, okay? These are some pictures from that study showing that those areas of the brain were erased. And this we're talking here people that were randomized, they had chronic back pain for many, many years. So what I tell my patients is the 5 M's. The 5 M's are self-management, things that they can do for themselves. If they learn movement strategies, mind-body strategies, modalities, manual therapies, use your medications when you need. I'm not against medications, but they may not need every day. They may need an anti-inflammatory when they have a nociceptive flare-up. And if they need, if this self-management is not working, and then we can help them with interventional injections or surgery. And that's the end of my presentation. I have a website where I have a lot of handouts. You can download my handouts for free. You just need to become a member. I have my courses that I'm putting a lot of, I'm creating a lot of courses for professionals, and I'm going to release them on my website. I have my book. This is for patients with chronic pain, and I have a YouTube channel that I have a lot of videos for people with chronic pain to do. I demonstrate exercises. I teach what is happening to their body. I demonstrate relaxation, mind relaxation. I talk about diet. I talk about sleep. I talk about what you were thinking about your pain, because what people think about their own pain has a lot to do on how they feel pain. I was talking yesterday with a patient of mine, and I asked her, what do you think is causing your pain? And she said, doctor, I have no idea. And I asked her, doesn't this stress you that you feel this pain for so many years and you saw so many healthcare professionals, and you still don't know what's causing this pain? And she was very distressed. She was very, how can I say, anxious about that. She said, yeah, how come that I don't know what is causing this pain? And then it was interesting that after I examined her, the only thing that I found positive in her body was myofascial trigger points. I said, the only thing that I can find here has a cause for your chronic pain is the muscles. I'm pressing this, it was the paraspinals in her dorsal area. And when I pressed those muscles, she said, yeah, that's my pain. And I said, that's muscle. And she said, that's it? I said, yes. And she did not have any nociplastic pain. I don't know how, but she had many years of pain, and I could not find any signs of central sensitization, no signs of hyperalgesia or allodynia. The pain was contained in that area. And she was so happy. She said, wow, this means that my pain is just muscle. Muscles like, heat, apply some hot packs, muscles like a massage, muscles like a TENS machine. And then I told her, for this pain, for this muscle pain, your muscles need 4 types of exercise, SSAR. Because your muscles are weak, you need strengthening, that's the first S. Because your muscles are shortened, you need stretching, that's the second S. Because your muscles are lacking oxygen, the muscles need oxygen to relax. So you need aerobics exercise, you need to pump oxygen, you need cardiovascular aerobics to pump oxygen to this muscle, that's the A. And then you need also to do mind body relaxation, that's the R, SSAR. And she said, that's the first time that someone is telling me what I have and how to manage. And most importantly, it's not drugs. Like, I didn't give her more pills. She said, I'm tired of taking pills. Everybody wants to give me pills. And I said, no, you don't need pills. You only need to do those things. So, and myofascial trigger points is a kind of nociceptive pain. Fortunately, she did not have sensitization and no neuropathic pain. So that's the end of my lecture. I'm not sure if there is a mechanism that you can ask me questions. I have a few more minutes here. If there are questions, I'll be happy to answer. I cannot hear you if you are saying anything. Hi, can you say something for me to see if I can hear you? Because I'm not hearing anything.
Dr.
Yeah, I can hear now.
Okay. All right. So yeah, we're done. I will get back to you, not tomorrow because tomorrow's the last day. So day after tomorrow, I'll be in touch with you.
Okay, thank you very much.
All right. Thank you so much.
Okay, bye.
Have a nice day.
You too. Bye.
All right. Bye.